He's a lecturer in the College of Medicine in Duhok City. He's also a radiologist and has fellowship regarding interventional radiology from both Turkey and India.
Actually, my talk will be about percutaneous ablation of parathyroid adenoma for the primary one. So the safety and the efficacy. My colleague also talk about the safety and efficacy. Really, from our perspective, it is. Okay. So really, it is a safe if you have good experience starting by FNA. If you have good experience about 500 FNA, then you can shift to treat the patient by percutaneous ablation whether for thyroid and parathyroid nodules. So actually, I don't see too much difference between, from my experience, by radiofrequency ablation and microwave ablation regarding thyroid. But it is it's better to start by radiofrequency because it's less invasive if you compare it with microwave, especially as a beginning. There is some difference regarding the physics about microwave and the radiofrequency. However, it is giving the same thermal ablation. We have only zinc effect was not important in the thyroid. Usually, it's important for the liver. The most important thing really is you have to know the anatomy because the neck is small area, but it's full of vital structures. So it's very vital to know about every details about in the neck. Because, for example, the vagus nerve is one of the main important structure in the dangerous triangle, we call it. And also we have not to forget the sympathetic trunk, the middle cervical sympathetic trunk, and also the esophagus, and of course the main vessels. Fortunately, vagus nerve, most of them, they are in the lateral side, and some of them in the superior side. And usually, when we start from percutaneous transisthmic approach. So we are going from the medial side to the lateral side. So usually we don't hit the area unless we are very aggressive. But unfortunately, we have still 2%, around 2%, the risk of injury to this vagus nerve, for example, or the middle cervical sympathetic trunk, which is very important, may end with disaster. So before doing the procedure, usually we scan by ultrasound. We have to identify the vagus nerve. Most of the time you can see it, and usually it is in the lateral side. But if it is in the medial side, we have to start with very good hydrodissection. So hydrodissection is one of main steps for a percutaneous ablation. And also, as I mentioned, the cervical sympathetic trunk is important. So hydrodissection is main step of the procedure. There are many studies, actually, about the efficacy and the safety of treating primary hyperparathyroidism. And as my colleague said, it's around 98 or 97% success rate. So even from the studies, success rate is 38 of 39. It's by Professor Baek. He's very important all over the world, Professor Baek from South Korea. And also, sometimes, according to the availability, sometimes we can use even ethanol ablation for the same purpose. However, it's more dangerous. And it's another study, for example, in India, and they mentioned that it's safe and it's an alternative for surgery. But usually, many patients, they come to me in the clinic, they refuse to do surgery because they have another option, which is less invasive, and you can do it as a day surgery. So the patient finish and he stay maybe 1 hour and then he can leave. And even after 1-2 hours, you can check the parathyroid and it will be normal if you have successful procedure. So usually, as like any procedure, we start by sterilization in the area. We usually do it under aseptic technique. It's one of the important things, and we use 1 to 2% xylocaine. And as I said, the main step is hydrodissection. Hydrodissection, we use glucose saline, dextrose. We use 5% dextrose for the cases of radiofrequency ablation. However, if it's microwave, because there is no conductivity, radiofrequency depends on the conductivity and it's closed circle. So normal saline, we don't use it, we use dextrose to avoid conductivity. But in case of microwave, you can use normal saline without any problem. Usually we use 10 cc to 100 cc for good hydrodissection. Complications, like in any other procedures, the hoarseness of the voice that we always afraid from this one. That's why we do it under local anesthesia only. We always continue talking with the patient, and just to know that if there is any change in the voice, that we have to stop the procedure immediately. And we have always spare cold dextrose that we use it in the dangerous triangle once there is change. And most of the cases, they just recover in the same time, within seconds. Also, we have to consult the endocrinologist regarding the post-procedure complication like hypocalcemia. So usually we have good connection with the endocrinologist to avoid the complications like, for example, hypocalcemia and even sometimes convulsion that I haven't seen yet. And if like any other procedures like skin burn and hematoma infection, usually if you do it under aseptic technique, you will be avoided. So usually we can use this technique from the behind, or we can use it from in front. But the important thing for this procedure, I think, it's you have to have both skills of both hands, because, for example, you have to use sometimes the probe in the right hand, sometimes you have to use to the left hand. This is according to the area, whether it's in the right and the left. These are basic techniques, transismic approach. Like thyroid, we use it in the parathyroid also. So transismic, it's less bleeding and less annoying and less penetrating the muscles if you do it in the transismic approach. That's why we prefer always to do it transismic. And another one is moving short technique. So if you, for example, if you started, you have to start it with the most posterior part and the most medial part, because you know, in any area of ablation, there will be echogenicity, there will be like bubbles. Once there is a bubbles, the ultrasound cannot penetrate beyond. That's why we use it in the medial side and the most posterior part. If there is bubbles, so we have no problem, because we are going to the more upper part, more anterior part. Like in this picture, you see, we start from the number 1, 2, 3, and we have to not forget the dangerous triangle, and then to go 4, 5, 6 like this. This is very important and basic for that. However, for parathyroid, you can use, for example, from other approaches, but usually we don't prefer. Hydrodissection, so we can use hydrodissection separately, or we can put the needle and stir the needle there and with the connection with the syringe, because you know normal saline or dextrose, it will be easily absorbed. If any, for example, maybe minutes, there will be no normal saline, it will be too little. But usually we use at least 5 ml dissection or isolation from the main structure to avoid any thermal injury. This is hydrodissection. We use it percutaneously for good hydrodissection. So the complications, you have to avoid all these. So the hydrodissection is we do it according to the area that we are of choice that we are going to do the procedure. So those all the areas that we can use it for thyroid, and for the parathyroid, it's mostly in the posterior part. So as in this picture, you see the echogenicities. Because the echogenicity once happened, you cannot see beyond. That's why you use it from this one. And this is your right side, it is completely ablated, and you see it all echogenicities within the lesion. So it's one, we use it, we do good anatomical, for scanning the anatomy of the area, because we have to know from the transverse, from the axial, and from the sagittal, so we have to know the anatomy around it. And for this, we do, as I said, a good hydrodissection. This is the normal saline. Color ultrasound is important to put because, you know, as my colleague said, polar artery is one of the main important things that you have to ablate it. Otherwise, there will be a recurrence. So this is very important. And how do you know that this is success? You will see all the air bubbles within the nodules after the ending of the procedure, and it will not take the color. One of the point, if you have, when you put the color on the ablated area, there may be some echogenicity or twinkling artifact that should not be mistaken with the vascularity. This is important point. For example, this is a young lady. She has very big one, parathyroid adenoma. So one of the important thing, I don't know whether this will be one of the points, especially for female, we do ultrasound for the vocal cord. So we do it before the procedure by ultrasound, not for male usually because of calcification you cannot see, or it's very difficult. And after the procedure, you have to check the vocal cord for any palsy or any weakness, because you can see it easily by ultrasound. So this is good hydrodissection of the nodule as you see it, and this is after ablation. Actually, this one is my first case. It was 2000, I think it was 2000, 2001 in June. So this was a lady, surgeon sent it to me, said you cannot give the anesthesia, and she has very big parathyroid adenoma. I had good experience before that for the thyroid, but this was my first case of parathyroid. And even the lab said we cannot measure the parathyroid hormone because it was too, the calcium, it was too high. So as you see, the parathyroid hormone, parathyroid adenomas, most of the cases, they are very vascular. This is leading us to diagnosis also. So after good hydrodissection on the area, we start moving short technique. So because this is big one, so it's not a matter, a small one you put inside constantly and ablate and finish. No, you have to ablate every part of that. Once you ablate, you have to check it because of, you have to check whether you ablate all the lesion or not, and this is after ablation actually. So you see there is no any vascularity for that. And as we see, there is only small incision for that and without scarring. This is one of the points that's too much attractive for the patients that without scar and under local anesthesia. Scintigraphy is important for some of the cases, although now we can use CT scan. CT scan, we diagnose most of the cases for cases that cannot be diagnosed by ultrasound. We give the contrast. Native, we do native, we do arterial phase, we do venous phase, and most of the cases you can diagnose even the mediastinal one. So this is after 1 day after the procedure, the calciums become normal. This is another case come from Baghdad. She was a young lady, and she seek for the non-invasive procedure. Actually, this report, she has many lytic lesions in the bone because of effect of hyperparathyroidism. And after doing this was the pre-procedure, and this was the B scan. And as you see, it's very vascular. It was very vascular lesion.
1 minute, Dr. 1 minute.
Okay.
Inshallah.
Oh, okay.
1 minute left.
Oh, 1 minute. Okay. So you see here we did ablation, and this is, if you pull the color, there will be artifact, and after that you see all things become normal with only small incision. This is another case. It looks to be a lymph node, but actually it's not lymph node. This is the same patient, but with another ultrasound, the procedure ultrasound. You see the polar artery that is supplying it, and after ablation, this is complete. So usually 2 hours, we have only 2 hours. After 2 hours, everything will become normal. As any procedure, we are not devoid from complications. This was it was VIP patients come to me, and she was morbidly obese. Too much recommendation about that. She was a teacher in the university. Okay, be careful about that and take care of that. She's beyond surgery because she's so obese. This is a serum parathyroid of her. Okay, we give the appointment because I give him my mobile number, and we kept in touch. And she was 60 years, I think, 60 something. So after the procedure, okay. During the procedure, after ending the procedure, there was some change in the voice. So I just reassured the patient, but the next day she said, I lost my voice. This was very disaster for me. So we keep in touch. After 1 month, still voice changed, no recovery. After that, 1 month again, after consultation, she went to consultation. Many ENT says, no, this is finished. I reassure that because this wasn't during the procedure. So because she was morbidly obese, but edema can happen. So, but unfortunately, she was a teacher in the university, and this has happened to her. So it wasn't easy for me these days. Until the 4th month, she went to Emirates for consultation. There, and then I sent her a text, and she replied with me with a voice. And that this was really something very important for me. And she recovered after let's say 3 to 4 months. So this is complication. You have to be ready for that. This is my last patient. This is another, so this is post-surgery. The surgeon, they sent from Erbil surgery, they did parathyroidectomy and thyroidectomy at the same time. And he was a young boy. So they said after 20 days of the procedure, all the parathyroid hormone was normal. And surprisingly, the biopsy said there is no parathyroid hormone in the biopsy, adenoma. This was the picture after 20 days. And we sent it to the parathyroid scan, and it was positive. So this was very difficult case because after procedure, you cannot see the anatomy. So I put the color, which is very important. You see the color. It was very vascular. So I did ablation, and after that, he get recovery the next day. So the conclusion is that really the radiofrequency ablation or the microwave ablation is a very safe, and it is an effective procedure from my experience of 4 years of this procedure. And usually we have to give, I think it's better to give this option for the patient that, for example, the surgeon, they have to give this option to the patient and give them the advantage and disadvantage of the procedure, because nowadays, everywhere, they give this option in the least that the patient have. Even the patient is fit one. Thank you.
Thank you, Dr. Thank you very much for thank you for the detailed lecture and the explanation about the intricate and exquisite details needed for the technique. From the eye of an experienced, it may seem like a simple procedure, but Dr. Sohaib told us how much consideration is needed before the procedure is actually done.